So today I'm going to present a small part of my PhD work that led to a collaboration with CAR T-cell preclinical company here in Adelaide, Karina Biotech. The work had a lot of interesting, interest from Mike Jensen at Juno Therapeutics, which is one of the leading CAR T-cell companies in the US. The work has been patented, and so we can talk about it now. Today I'm going to talk about this small part. So I think you heard about the CAR T-cell therapy from a presentation a while ago. So the process involves, how do we change the slides? So the process involves, I didn't explain it here, but the process involves taking the immune cells from the patient who has a cancer, and then you take these cells, you genetically modify them by inserting a receptor against that cancer. Then you expand the cells to reach a certain dose, and then you transfuse it back to the patient to kill the cancer. Now the whole process takes about 2 weeks, taking the cells from the patient, separating the desired immune cell, modifying it, and then expanding it to reach the right number. Now, because this process is a lengthy process, you always end up with a CAR T-cell product that has limited viability. The viability is low, depending on what genetic modification process you used. Also, the product itself has to be stored in something to be shipped to the treating facility, which is a hospital, where the product is not being produced. So usually this CAR T-cell product is produced in a central facility, and then shipped back to the patient as frozen. Now, this freezing, thawing process also results in the death of the cells. So there is cryoprotectant there, and there's low viability of the cells. All of this, or dead cells, they cause bad reactions in the patient. Usually, this is a very debilitated patient. It can cause allergic reactions, it could cause anaphylaxis, toxicity, and actually it had resulted in a lot of problems for Novartis, who had this issue of viability with their Kymriah product. Yeah. So our aim was to design an inertial microfluidic technology where we are able to remove this cryoprotectant and enhance the viability. And after doing that, we wanted to see the effect of this approach on the characteristic of the CAR T-cell product, whether we affected the percentage of CAR-positive cells, which are the cells that will kill the cancer, whether it affected the desirable phenotypes or not, because there are certain T-cell phenotypes that are important for treatment, and whether it affected the CAR T-cell functionality in terms of killing the cancer. So, first of all, our inertial microfluidic technology is actually based on a design by my co-supervisor at UTS in Sydney, Dr. Majid, and the principle is very simple of an inertial microfluidic device. So based on a difference in size, based on a difference in density or deformation of the cells, you're able to remove larger from smaller size cells, or they have different characteristics. So it's a simple principle. So what we did was we first of all designed these chips. The SU8 mold itself, we designed by photolithography at the NFF South Australian node. And then we made these PDMS devices from our mold by soft lithography techniques in our labs, also at the University of South Australia. And then we tested it with CAR T cells. So they were low viability batches, and they were given to us by Karina Biotech. And they were cryopreserved in CryoStor, which is the commonly used cryoprotectant in the CAR T cell industry. And then we looked, so we optimized the device through the operation of the device. And usually they wanted it to be reconstituted in plasma-like, which is the typical diluent that is injected into the patient. So we had to optimize a variety of operation parameters in that device. And then we were able to achieve some results. Okay, so we were able to actually deplete 70% of the dead cells. We did lose some live cells as well. However, we were able to recover 80% of the product. This has resulted in enhancement in the viability of 20%, and the viability enhancement of 20%, and we were able to remove 92% of the cryoprotectant as we tested it using capillary electrophoresis. Then we looked at the characteristics of the CAR T cell product that we got out. There was no effect on the percentage of CAR positive cells, but definitely as we got more feedback about that, which is something that needs further validation and look into, is that it depends also on the expansion protocol. So what expansion protocol used by the manufacturer can affect what you get out from the device. Okay. On the phenotypes, we have noticed that we did get an increase in central memory phenotype and the depletion of the terminally differentiated, which is the MRS cells. This is something that is important in the immunology field because central memory phenotype is known to persist longer in a patient. And usually products that have a higher percentage of central memory phenotype usually produce a better response. However, in our case, it wasn't such a great enhancement, but it's good to know that our process didn't affect the characteristics of the CAR T cell product itself. It also led to a slight depletion of the Tregs and T suppressor cells, which they were not important in the treatment. Effect on CAR T cell, then we looked at the effect on the CAR T cell proliferation and cytotoxicity. Now, this work was done at the Women's and Children's Hospital, where we got, we got a cancer cell line. It had a luciferase reporter in it. And then we added our processed CAR T cells that were run in the device and the ones that were unprocessed. And we looked, and actually we got a slight increase, enhanced response with the processed CAR T cells. But I mean, the end of this, it just shows that it does not affect the functionality of the T cells. So the conclusion is that we definitely can process the CAR T cell product with inertial microfluidics. We can enhance the viability of the frozen product. And because microfluidic it can be integrated in closed automated devices, it can actually be used as a point of care device in a treating hospital for thawing. Like after thawing the cells, it can just formulate the product into plasmolite, which has no cryoprotectant and probably an enhanced viability as we saw, and before injecting it into the patient. And that's the end. I would like to thank, of course, my supervisor, Professor Benjamin Thierry. I'd like to thank all the people at the NFF South Australian Node for helping me with my device. I'd like to also like to thank my supervisor in UTS in Sydney and all my other supervisory panel, as well as Karina Biotech, because they supplied us with the cells and they helped us meet Mike Jensen and get that happening. Thanks a lot. Thank you.
Questions, you can't get away that easily. So just a couple of quick questions. How long does it take to process a sample through this process? Is it possible to recover cells of different cell densities?
Yeah, so it's a good question. We actually looked at different cell concentrations in the device, and we are able to process up to 1 × 10⁸ cells in the device. Now, this device is operated at a flow rate of 1 milliliter per minute. So if we have a vial, usually the vials that we used to get were 1 × 10⁸ to 1 × 10⁹. We can process it in about 10 minutes. So from 10 to 20 minutes, depending on what cell number we're getting.
Thanks, Mona. Second one, when do you use the devices, before or after the in vitro expansion? Yeah, so this optimized thing, or this patented thing, is to be done after the expansion process. So either after the expansion or after expansion, freezing and thawing. So at the treating hospital. So the main thing was to enhance viability, whether before you freeze it down and send it to the hospital, or as making like a finished point of care device at the treating hospital, just to clean up the product before injecting into the patient. Thanks, Mona. There's one other question. I'm nervous because I don't know if it's a quick answer, but I'll ask it anyway. What markers do you use to distinguish different T cell subsets? Yes,
so we use the CD45RO and CCR7 to look at the central memory, effector memory, MRS, and the naive cells. We also looked at the CD45RA. There are a number of markers, actually. And then the suppressor and the Tregs we used, CD125, FOXP3, what else? We used another one, CD25. So there are not, CD25, so we use a lot of them.
I suspected that sort of.
There will
might
be
the
panels,
answer.
yeah.
There's
So
a-
in the paper now, it's accepted now, because we finished the patent, you'll find all the markers that we used in that.
So so Crystal's asked that in Slido, so if you want to answer more
Yeah,
specifically,
yeah,
feel free.
definitely, yeah.
Let's thank Mona one more time.
Thank you.